السلام عليكم ورحمة الله وبركاته، مساء الخير جميعًا وأهلًا وسهلًا بكم في اللقاء الرابع والأخير من سلسلة المحاضرات العلمية التي ينظمها نادي الأشعة ونادي العظام بكلية الطب بجامعة جدة. محاضرتنا اليوم بعنوان تصوير الجهاز العضلي الهيكلي بالرنين المغناطيسي، ويسعدنا أن نستضيف الدكتورة مشاعل الرشيدي طبيبة الأشعة التشخيصية للجهاز العضلي الهيكلي في مدينة الملك فهد الطبية بالرياض. كل الشكر والتقدير للدكتورة على وجودها معانا اليوم، ونتمنى لكم جميعًا محاضرة ممتعة ومفيدة. تفضلي دكتورة حياك الله.
الله يحييك والله يعطيكم العافية على الترتيب والتنسيق. طبعًا الMSK MRI it's a little bit complex topic, so I tried my best to be for the lecture to be more useful and as a bridge for you to read and understand the role of MRI and the role of MRI in MSK. These are my objectives. First, we'll talk about the indication and contraindication for MRI. We'll understand the basic MRI sequences, and we will learn the essential terminology used in radiology reports, and we will identify common pathologies and how radiology reports guide in the treatment. First, the indication. The indication for MSK MRI. In cases of trauma and sport injuries, we'll identify bone bruises, stress fractures. In case of normal X-ray, we'll identify ligament injuries. We can differentiate between complete versus partial ligament tear, meniscal tear, if there is a displaced fragments, and tendon tears like rotator cuff, Achilles tendon. It helps us to differentiate between if there is a tear or not, and if there is a tear, if it is complete or partial, and if we have a complete tear, if there is a tendon retraction and muscle atrophy, because this guides the management of the patient. Muscle strains and contusions. In case of degenerative disorders like intervertebral disc disease, labral tears, and the shoulder and hip. In cases of inflammatory and infectious diseases like inflammatory arthritis, we can see if there is an active inflammation, and this guide in the biologic treatments. In cases of osteomyelitis and septic arthritis, sometimes we need to see if there is a collection to be drained. Sometimes the ultrasound and CT is enough, but sometimes we need further imaging to further characterize this collection, because sometimes the collection is in its early stages. It's not completely liquefied centrally to be drained. For the tumor and masses, we want to see if the tumor is, let's say, rather than benign and malignant, we say aggressive versus non-aggressive, and soft tissue tumors will need the MRI for localization, staging, and to see how the invasion to the surrounding structures. We need MRI also in pre and post-operative. In the surgical planning, we want to see if there is invasion to the surrounding structures, sometimes graft selection. Because sometimes when we have like ACL tear, we want a graft. So we want to see like if there is a plantaris tendon, we can use it, popliteus tendon, and not quadriceps, patellar tendon. So we need to see the integrity of the graft first, if it is good or not, or if we can use it or not. Post-operative complications, if there is a re-tear, infection, or hardware issues. Unexplained symptoms. Sometimes we have a persistent pain with normal X-ray. So we will move, the patient is still complaining of pain. Clinically, there is nothing to explain this pain. So we can do MRI to assess further. Unexplained swelling or mass, and restricted motion without clear cause. The contraindication of MRI, we have absolute contraindication, like non-MRI compatible devices, like pacemaker, ICDs, metallic intraocular foreign bodies, cochlear implants, implantable neurostimulation systems, drug infusion pumps with metallic electronic parts. And sometimes we need to ask we need to ask the cardiologist if this device is compatible with MRI or not. By knowing the metallic type or the metallic material used, like titanium is compatible with MRI, and some materials are not compatible. So we need to ask about this. Sometimes we have a relative contraindication, like renal insufficiency in case of low GFR. If we need contrast, because risk of nephrogenic systemic fibrosis. In case of pregnancy, especially when we use contrast. In case of claustrophobia, the patient cannot tolerate sitting in closed space. Why MSK? Why MRI in MSK? It has excellent soft tissue contrast, multiplanar imaging, and non-ionizing radiation. First, we need to know the planes. We have this, the yellow one is the axial plane. This is how we see the knee MRI. It's cutting from up and down. The sagittal plane, we can see the images from side to side. This is the sagittal. And the coronal plane, we will see it from anterior to posterior, and this is the coronal plane. These are the three planes used in MRI in general. And in MSK, we have the oblique, like oblique, sagittal oblique. When we want to assess the ACL, we want, not the ACL, sorry, the shoulder, the rotator cuff. Sometimes we need to be parallel because to visualize the tendon clearly, we need to be parallel to these tendons. Then what are the basic MRI sequences? We have T1 weighted images. It is good to demonstrate the anatomy. T2, it is good for the pathology. Stare and fat, it is good for edema and inflammation. We suppress the fat because both in T1 and T2, the fat is bright. And in stare and fat saturated sequences, it exaggerates the edema and inflammation because we will suppress all the fat in the body. Proton density, this is a specific sequence used in MSK. It is good to visualize and assess the cartilage, menisci, and ligaments. Here is the sagittal BD, and here is sagittal T2. Here we have sagittal T2 fat saturated because we can see the bone marrow. Bone marrow is composed of fat. So here with fat saturated images, we see the bone marrow is dark. So any edema will show up. Here's the coronal T1. We can see the fat, the intramedullary fat marrow is bright. The normal anatomy on MRI. First, we will talk about the bones. We have a cortical and medullary bone. The cortical bone is dark on all sequences, as we can see here. Do you see my mouse?
ايوه واضح دكتورة.
ممتاز. And we have this, the medullary bone. Medullary bone is composed of fat, اللي هو نخاع العظم. So when we see abnormal changes on the bone, we need to assess it first on T1 weighted images. So as we see here, we have low T1, and the medullary bone. But this signal is not lower than the skeletal muscle. So this is either edema or red marrow. How to differentiate? We'll go to the fat saturated images, T2. If it is high as this one, it represent bone marrow edema. If it is suppressed, this is red marrow. Then we will go to the joints and cartilage. The cartilage in histopathology, it has 6 layers, but in MRI we have 3 layers. This is the first one. This is the patella, by the way, in the axial images. This is the first layer, the dark line, and this is the second layer, and this is the lamina splenda, the last layer. If there is any arthritis or disease affecting the cartilage, it will start from here. You will not see this dark line. And sometimes in cases of a trauma, you will see sharp demarcation or shouldering defect in the cartilage. The synovium, it is important in arthritis and rheumatoid arthritis when it is inflamed. We need to see the synovial enhancement to assess if there is active inflammation or not, to assess for biologic treatments. But for the muscles and tendon, we need to know the normal muscle texture and the tendon and ligaments, low signal in all sequences. We can see here the muscle. It's better to assess the muscle first on T1 اللي هي يكون فيها الفات برايت. طبعا كيف نفرق بين T1 وال T2؟ الكي فاكتور إنه نشوف الفلويد. If the fluid is bright, this is T2. If the fluid is dark, this is T1. هذا as simple as that. But sometimes we have يعني additional sequences like fat suppressed. We need to know about them all. فهنا we can see the supraspinatus muscle. It's good bulk on T1, and in image B we can see fatty infiltration. This is indicating atrophy. And what's the point and why do we want to know about muscle atrophy? Because if there is a supraspinatus tendon tear, we cannot repair it if there is fatty atrophy. There is no point of repairing tendon while the muscle, while its muscle is not working. Here we have, this is the normal Achilles tendon. As you see, it is very dark signal. Here we have Achilles tendon complete tear, and you can see the tendon is retracted. So what is the key terms and reports? We need to know what is the meaning of hyperintense, hypointense, heterogeneous signal, contrast enhancement, boomer edema, joint fusion. طبعا high signal means hyperintense. Low signal mean hypointense. The hyperintense on T2 means most likely means fluid, but we need to see what is the signal on T1. The fluid is high on T2, low on T1. The fat is bright on T1 and bright on T2. How to make sure this is 100% fat? We'll use the fat saturated images when we suppress the fat so we can see the images without fat. Sometimes we need this in cases of fatty lesion, like lipoma. We need to add fat saturated images. And most of the time we use T2 fat saturated images. We don't usually use the pure T2. Heterogeneous signal means this is something abnormal most of the time, especially when there's a heterogeneous contrast enhancement, most of the time, because of this is something abnormal. So we have area of vascularization and area of non-vascularization. Bone marrow edema, it's a general term, and in every clinical scenario, it means something. And if in every location, it leads to different diagnoses. So common pathology, we'll need to know about the edema, bone marrow edema, muscle edema. So this is our general terms. If we have bone marrow edema, we want to know what is the reason of this bone marrow edema. Is it bone marrow contusion? يعني after trauma, the patient is having a trauma. نفس الكدمات اللي تصير في skin. The bone has bone marrow contusions. Muscle edema and muscle strain, it will also present with edema. What is the meaning of edema? Fluid. يعني high في T2, low في T1. الإديمة زي ما قلت إنه it can be related to multiple reasons. ممكن يكون related to mass compressing the muscle, causing impingement, or sometimes a strain or injury after trauma. Second, the tears, it's in the tendon or ligament and meniscus. And the cartilage loss in cases of osteoarthritis and trauma. And we need to know the pattern of cartilage loss. Like in osteoarthritis, we have generalized thinning of the cartilage because it's degenerative. In trauma, we will see a focal focal defect يعني كأنه tear. الكارتلج full thickness tear. Focal full thickness cartilage loss. Masses on collection, we need to know the mass, the characterization of the mass. If it is fatty containing, we'll go for more to lipoma or fat containing lesions like lipoma, liposarcoma, teratoma. And if it is cystic, we have other differential. So this guide in the differential diagnosis. First, in the trauma and bone injury, bone bruises versus fracture. Bone bruises mean bone marrow edema in the setting of trauma. لكن الفراكتشر we have a visible cortical defect. A stress fracture, in stress fracture we will see edema before the fracture line. So MRI is the most sensitive for occult fractures. Sometimes we have missed injury on X-ray or not missed, it's not visible on X-ray and the patient is complaining of pain after trauma. We need to do MRI to see if there is a stress fracture or a fracture related to anything else. So this will help us to prevent delayed healing. We can see here the stress fracture. It's a very tiny cortical, low T1, low T2 cortical line with edema, significant edema. Here we can see the bone contusion. It's a marrow edema. So you can see the image, the fat all over is suppressed. So the edema and inflammation will be bright. After that, for the ligamentous injury or menisci in the knee, ACL, we will see discontinuity, empty notch sign, anterior tibial translation. Anterior tibial translation equal to anterior with anterior drawer tests. When we try to pull the tibia, it will come anterior to the femur. Meniscal tear, we have either vertical or horizontal, and sometimes we have a displaced fragment. And all of these will determine the management. So because sometimes when we have a simple meniscal tear, it will be treated conservatively, or sometimes when you have a displaced or unstable meniscal tear, this will need surgical management. And this also determined by the ortho. So we need to give them the appropriate information to decide what to do to the patient. Here we can see the normal ACL. We have two bundles, anteromedial and posterolateral, and that's why it is, you can see the striation, which is different to BCL, which is one bundle, it's dark. Here we have torn ACL. You can see the discontinuity. For the menisci, this is a sagittal image, and this is the femur, and this is the tibia, this is the anterior horn, and this is the posterior horn. This is the normal shape of the meniscus. It's very dark, triangular. Here we can see vertical tear. It's a fluid signal insinuating. For the rotator cuff tendinopathy and tear, tendinopathy, it's just a thickening and heterogeneous tendon, but the tear, it's a gap, fluid signal. Here we can see the normal rotator cuff, and here we can see the fluid. As I told you before, the T2 fat saturated images, it's very useful to assess the pathology. Then we will move to degenerative and inflammatory joint disease. Osteoarthritis, we have cartilage thinning. It's related to aging, or it's mechanical rather than something traumatic. So we will have a generalized cartilage thinning without focal defect. But in inflammatory arthritis, we will have hypertrophy, synovial hypertrophy, erosions, bone marrow edema. In case of rheumatoid arthritis, we need to see the post-contrast images to see if the patient is having active inflammation. And this will determine if the patient need to change the biologic treatment. For the infection, we have osteomyelitis. when we have marrow edema and enhancement to adjacent soft tissue abscess. Sometimes it's really very difficult to differentiate between osteomyelitis and tumors, the aggressive one. That's why in MSK we don't say malignant and benign. We say aggressive and non-aggressive. And the aggressive, it contains the malignant bone tumors and osteomyelitis as well. But when we will have soft tissue mass, this will make it easier for us because we have a mass. So, and always, if you are not sure if this is a malignant or benign, I mean the aggressive lesions, do biopsy. The management impact, I will talk shortly about the management impact. Like in meniscal tear, as I said, if the patient is having mechanical symptoms and displaced tear, this is likely it will be managed by arthroscopic surgery. If it is stable and degenerative, we can go with physiotherapy and conservative care. At the rotator cuff, if we have a full thickness tear in active patient, and we should know if the muscles is not atrophied, we can do a surgical repair. But if we have a partial tear or tendinopathy, we'll go physiotherapy, injection, and conservative management. In case of trauma, bone bruises, no surgery is needed, just supportive treatment like rest and physiotherapy. But we need, but the MRI will, or the presence of bone bruises will explain the patient symptoms when the X-ray is normal. And we need it also to rule out associated ligament and meniscal injury. How reports guide the treatment? It will confirm clinical suspicion and identify surgical lesions like complete ACL tear, rule out mimickers like infection, tumor, inflammation. Sometimes they are overlapping, and follow up and prognosis. Take-home points, you need to know the anatomy first. Sometimes we have normal variants in MSK. It can be mistaken for lesion, like we have something in the deltoid, in the insertion of the deltoid and the humerus. There will be like in some patients, there will be cortical thickening and expansion. So sometimes it can be mistaken for a mass or a lesion. So when you know this is the insertion of the deltoid and there is a existing condition called like osteodeltoitis, so you know this is something normal. It's not something to worry about. Always correlate with the clinical history. Clinical history is very, very, very important. And sometimes we get requests from the primary without explaining his clinical concern. They said pain and that's it. We need more history. What is the pain? Is it chronic or acute? Is there a history of trauma or not? We need to take the clinical history to complete the picture. As you know, we are treating the patients, not the images. And we should know how the radiology reports guide the management of you are ordering like a shoulder or a knee MRI in cases of a trauma. I need to know what I'm looking for. If I am looking for meniscal tear, or if I am clinically the patient is presenting like with ACL tear, what I want to know about this ACL tear, if it is complete or not complete, if it's a striated injury, if there is a striated injury with it or not. So all of this information should be in mind before requesting the MRI. And providing good clinical history always help us and help the physician first, the referring physician first. And thank you so much. If you have any question, you are more welcome. Thank you so much for your attention. I really appreciate the organizing committee. Thank you so much.
نشكرك دكتورة مشاعل على المعلومات القيمة ووقتك. والله يعطيك العافية، وشكرا للحضور.
الله يعافيك. إذا في أي سؤال تفضلوا. الله يعافيكم جميعا، نتمنى أنكم تكونوا استفدتوا.